Dear friends, it's been 9 Respinars over the last 2 months. We have discussed various topics involving nearly about 40 panelists, more than dozen of experts and moderators all across India, and with wonderful inputs, insights and learnings. We continue our journey. I thank you all for joining in and also request you to keep tuned and keep joining and keep enjoying this Respinars and be a part of this Respinar by being not only as a faculty but also as a delegate in each and every episode.
Hi, good evening everyone. This is Dr. Richa. On behalf of ICS, I would like to welcome you all for this evening Respinar, the weekly Respinars we are doing. For the month of April, we have chosen the subject Interventional Pulmonology, and every week we would be dealing in particular role of interventional pulmonology in particular areas like parenchymal disease, airway disease, or the future of the interventional pulmonology. For today, we are having expert Dr. Ajmal Khan, and we have our moderator Dr. Pratibha Singhal, and a fleet of young pulmonologists who have been doing interventional pulmonology at their respective centers are doing the good job. The topic for today's Respinar is interventional pulmonology in airway disease, and I would like to welcome you all once again, as well as our faculty for tonight's Respinar. Before I hand it over to Dr. Pratibha Singhal, I would like to thank our knowledge partner, Glenmark Pharmaceuticals, for providing us the platform where we can share our knowledge with each one of you. Over to you, Dr. Pratibha.
Thank you, Richa. Good evening, everyone. We have an august panel of experts here, starting with Dr. Ajmal Khan, who's the lead expert. He's, of course, as all of you must be knowing, he's the additional professor at the SGPGI Lucknow. They have one of the state-of-art bronchoscopy suites and all the armamentarium needed for interventions. Then we have Dr. Sameer Arbat, who's a young interventional pulmonologist from city of Nagpur. We have with us Dr. Praveen Valsalan, who is from Ernakulam. He's also another young pulmonologist. And we have Dr. Pradeep Dhabi from Ahmedabad, another young interventional pulmonologist. I think Pratibha Gogia has just, Pratibha Gogia is here. So Pratibha, hi, good to see you. And she is a dynamic pulmonologist from the city of Delhi, and she has trained with Dr. Rajiv Goel, and she is doing great interventions in her own forte. So with that, I would like to start our panel discussion for today. So to start with Dr. Praveen, the first question is for you. What would be the common
Thank you for giving me the opportunity for me to be here. So if you look at the commonest interventions, the bronchoscopic interventions that we talk of, it could be either a diagnostic or as well as a therapeutic one. But if like in any hospital of the commonest airway or the bronchoscopic thing that we do is taking a bronchial wash or a bronchoalveolar lavage. That's like, say, a patient who has a pneumonia or who has something like a train burden appearance or something who has a non-resolving pneumonia. But more intervention-wise, what are the things that we commonly like? Say, for example, a patient who has a significant mucus plug and who is unable to remove it. We do perform a lot of mucus plug removal. Things like, for example, a patient who has a difficult intubation. We use a bronchoscopy to do the intubating the patient. And if the patient comes with an hemoptysis, especially a massive hemoptysis, we either do an flexible, or if the experience stands, we do a rigid bronchoscopy to clear off the blood and to block the bleeding area, to find out which area it is, and then as well as the removal of the blood clots. And for example, if the patient, if in a higher centers, we do a lot of endobronchial things, like, for example, tumor removals for both as a diagnostic as well as a therapeutic thing, especially blocking the major airway, central airway, or for that matter, even and the bronchi, the major bronchi. The other thing, like for example, a patient who comes with an stenosis, or for example, an extrinsic or an intrinsic compression, then like say things like airway recanalization, stenting. Those are the things that we do at and specialized centers like us, where we all work. We can do airway things like, for example, taking lung biopsies, transbronchial lung biopsies for DPLA, like a cryobiopsies, etc. for DPLDs. And of course, there are a lot more other bronchoscopic intervention, like say for an asthma, we used to have the bronchial thermoplasty. The COPD, we have a lot of airway interventions, like for example, interbronchial valves, interbronchial coils, vapor therapies, and probably more ones like, for example, RF ablation, or other more things which is in the pipeline. And I'm sure these are all things that is going to come. So these are the, in short, and probably the most commonest one that we perform. That's what I basically wanted to speak of.
Great. So I think primarily we can divide it into malignant and benign airway interventions that we do for what most of us get referrals for. So to take it forward, we're going to broadly move in these two directions. And Dr. Ajmal, my next question is for you. What would be your approach for airway obstruction in malignant disorders?
Basically, when we encounter any airway obstruction, first of all, we need to define this airway obstruction clinically, whether it requires any kind of intervention, or it can be further managed with other modalities of the therapy. So clinically, the most important sign is the stridor. If the patient has a stridor, that is immediately patient requires a intervention. So if it is not there, then we have to look for the other signs of like cyanosis, or what kind of symptoms he has, whether he has a symptoms of dyspnea during the rest or only during the exertion. So because it defines the critical nature of the airway stenosis. So once we have decided clinically this patient is having any kind of a airway obstruction, then we have to perform a radiology. Most of the time, a major decision can be taken through a radiology, particularly a CECT of the chest. Why we are asking about the CECT? Because it will also delineate the lymph nodes or any other kind of a vascularity of the lesion, so the further intervention can be easy. And when it is required to do an intervention, it is better to go for a 3D reconstruction of the lesion, so that it can be better defined. And there are certain landmarks in the radiology. There are certain landmarks, which is that from the vocal cord or from the main carina, we need to define the lesion, so that we can decide what kind of intervention we are going to do and what approach we need to take. Because if the lesion is too close to the vocal cord, it will be a difficult kind of a situation. So we have to prepare for that kind of a situation. And once we have decided everything, then we will subject the patient for a quick initial lookup diagnostic bronchoscopy, preferably during the procedure, or maybe if the patient is stable enough, then we can do it prior to the procedure in a bronchoscopy suite. So in a recent time, what I have seen is that when the patient is subjected to the bronchoscopy, most of the intervention does not know what we are going to find. But my main approach is to delineate the lesion beforehand when we are subjecting the patient to the bronchoscopy, because we just need to confirm what we are going to get during the lookup bronchoscopy, flexible bronchoscopy I'm talking about. Because it is always better to have a surprise rather than have a planned and anticipated kind of a lesion. So once when we are doing a bronchoscopy, flexible bronchoscopy, we can see the extent of the lesion, we can see the vascularity, we can see the amount of narrowing it is causing to the lesion, and there is any associated fistula or not, because all these features will ultimately decide what kind of a further procedure you are going to take. Once all these lesions has been well defined, then only we subject the patient to the any procedural details.
Great, Ajmal. I think what you mentioned about radiology is also important because you need to know whether it is completely only an intrinsic obstruction or whether it is partly a extrinsic obstruction. Like for example, in the trachea, we can sometimes get stridor, as you mentioned, even with large esophageal malignancies which are causing compression, right? So I think that's a great point that you said, because that will change your approach completely. And if you have the option, if it's not a dire emergency where you need to intervene, and if there, there's a tracheal mass which is completely near occluding the lumen where you need to do an immediate check plus therapeutic bronchoscopy in the same sitting, it is always better to do a check, evaluation bronchoscopy followed by a planned therapeutic intervention, as Ajmal has said.
It is not only, ma'am, we want to do as radiology. Radiology is the must. Because if you are doing a bronchoscopy, and suppose even if you are not able to do the prior bronchoscopy before the procedure, once you have taken the patient into a OT table and then you are doing a flexible bronchoscopy, you just know the lesion, then at that time you have already decided what procedure you are going to do. And sometimes it throw you a very surprising kind of a lesion. Like I will tell you one lesion we have. This patient was having a left main bronchus obstruction, a lady. So we did the flexible bronchoscopy and did the endobronchial biopsy 3 times. Because all these times it was showing the superficial part were necrosed. So we thought what we are getting is the necrotic part, because it was always showing aspergillus. So it is very common to find this malignant lesion to have a necrotic area, and that necrotic area are colonized by the fungal elements. So we thought it is a aspergillus. It's a colonization of the necrotic area. So we subjected this patient for a coring. So before coring, we just pinched the lesion, and that lesion of approximately 5 centimeter came out with the forceps only. But when we turned out our head towards the rigid bronchoscope after removing the forceps, we had all the 5 liter out of the rigid bronchoscope, and patient immediately died on table. So later on, when we subjected that for a histopathological examination, it showed that it was a invasive mucormycosis which was invading a pulmonary artery. So it is always better to have a definitive diagnosis before doing any kind of a airway procedure, because sometimes it may not give you a time at all to further go ahead with the therapeutic or palliative procedures.
Correct. So to take that point forward, Ajmal, I think, as I always say in all the webinars related to interventional pulmonology, your best friend has to be a CT radiologist.
Yes.
Because that is a person who is going to tell you what you can come up with during the procedure, which you can prepare for, so that you don't have problem shootings like what Ajmal has just said. Because if you lose a patient on table with insanguinating bleed, it is very, very disheartening.
Yes.
Okay. So moving forward, Samir, my next question for you is, you have identified that there is a lesion in the trachea or the bronchus which is causing obstruction and it needs to be removed. What would be your choice of modality for debulking or ablation? I mean, would you use a cautery, laser, APC, cryo? What would it be?
Yeah, so there's a long list of. Am I audible? Yeah.
Yes.
So right now we have a long list of options available when it comes to debulking. But as Dr. Ajmal said, a lot of emphasis has to be given on the radiological aspect. We've seen a lot of patients in our personal practice wherein we saw that the patient underwent a CT scan, or we even subjected the patient to a CT pulmoangio, and we could find the feeder vessel, and we sent the patient for a bronchial artery embolization before going for a debulking. And we've even gone for debulking wherein we realized that the patient was bleeding a lot. Later, it turned out to be an hematoma or something which can actually be very catastrophic. So a lot of emphasis has to be given on the CT. And when it comes to debulking, there's a lot of literature available which clearly defines your modality should depend whether the lesion is extraluminal, intraluminal, or a mixed lesion. So when we are talking about something which is intraluminal, we have almost all the modalities, which is mechanical debulking, that is coring with the rigid bronchoscope, the electrocautery, the laser, the APC, the cryotherapy. But when it comes to an extraluminal lesion, then probably you are not going to help the patient much with any of these. And if it is a mixed lesion, then obviously you can use any of these and then maybe follow it by a stent. So the most commonly available is the electrocautery. There's a lot of literature which states that the results with the electrocautery are acceptable, similar to the laser. And in a scenario like India, where we are, it's a price sensitive issue, and also we are resource limited. So I think so for most interventional pulmonologists, the electrocautery works fine. You need to have certain precautions. Obviously, the patient has to be under general anesthesia. Whenever you are performing the electrocautery, your first complication that you have to take in mind is a fire, endobronchial fire. So you need an anesthetist who's had some experience with endobronchial electrocautery or APC. And along with the electrocautery, a lot of centers nowadays have the APC. The APC compared to electrocautery is a non-contact modality. Advantages are here is that you have various forms of APCs which can direct tangentially or direct your APC fire directly in front of you. And the problem here again is the costing. One complication more with the APC compared to electrocautery is the gas embolism, for which you need to just modulate the rate of gas supply that you are doing. Followed to this are two types of lasers, the Nd:YAG laser and the holmium laser. Few centers, if you have a urology setup with you, you might be uh, privy to the holmium laser if your colleagues are ready to share it with you. Otherwise, the Nd:YAG laser is there. Both these machines are extremely expensive. To the cautery and APC here is if you overdo it, you might cause a tear or rupture in the trachea itself. So, considering all this, the electrocautery should be your first and most dependable tool. Cryo has come up as a very important tool in multiple ways. So, cryo can be used for cryo devitalization or cryoablation, wherein you actually touch your cryo probe to the target tissue, activate it for around 30 to 60 seconds, and let the tissue be. You can then follow up with a bronchoscopy after 7 days or 14 days, and just to see how the tissue has now reacted to the cryo ablation. Or you can use cryo as a cryo extraction tool, wherein you actually touch your cryo probe to the target tissue, activate the cryo probe, and pull out the tissue en bloc with the bronchoscope. Your worry here is mostly bleeding, which happens almost every time. And this can be controlled with cold saline and having a Fogarty balloon, which is your lifesaver whenever you're using a cryo. And last is, as we discussed, if it's a mixed extraluminal and intraluminal, then you have to follow up these things with a stenting. So these are the options that we have when it comes to debulking a tumor.
Dr. Samir, I would like to add two things. One is that you talked about the laser Nd:YAG versus that holmium. We are using at our center. We have our own laser, and we have that dual kind of Nd:YAG and holmium. So what we find is a holmium laser has the depth of penetration is less than the Nd:YAG laser. It is 4 mm of with this Nd:YAG, but it is around 2 with holmium. So it is always in the airway intervention, it is better to use a holmium if it is available. The another thing is in the three major centers in India, PGI Chandigarh, AIMS, and our center, what we have experienced is whatever the data we have available is available from the West. And there the amount of lesion is very, very small as compared to our patient, because when our patient comes, they just come just before they are dying.
Yeah.
So sometimes the lesions are huge. So if you start doing all kind of this electrocautery, laser or APC, it will take a whole day. So it is mechanical debulking in all these major centers. More than 70% of the patient are being this airway obstruction has been removed with the help of a mechanical debulking with the coring of the rigid bronchoscope. So that is one major option we have in our setup, rather than all these kind of these are very useful modalities, but when the lesion is small as compared to when the lesions are very large.
So just to continue that, Ajmal, I've seen a lot of youngsters when they start doing rigid initially, they are very wary of doing this mechanical coring, thinking of the catastrophic bleeding that can happen.
Yes.
So what would one do? I think the advantage with the rigid is that you can use the rigid itself to kind of give pressure and,
Yeah.
what other techniques would, just for the youngsters?
I'm telling you, ma'am, when you are using a coring, mechanical coring with the rigid bronchoscope, it has a swivel end.
Yes.
Through which we cut the lesion. And what happens while passing through the lesion, while cutting and passing through the lesion, the rigid bronchoscope itself as a makes it as a tamponadic effect. So if we are keeping the rigid bronchoscope there and there only for few minutes, it will stop the bleeding unless it is very vascular lesion. So that is why when there is a very, very vascular lesion, we avoid doing this coring business with the rigid bronchoscope.
Yes.
Other modalities are better than the coring.
Yes. The other thing that I think Samir brought up very well in his thing was about, if it's a very vascular lesion, then you do you involve your intervention
embolization before the lesion. That is a very good option.
So that's a very good option, which I think, one, again, as I keep reiterating, that your radiologist has to be your best friend. They should call you up and tell you that, listen, this is a problem here. You need to think about what to do.
One principle that I have learned from the late Dr. Dheeraj, he always used to say, as a interventionist, you should always know when to say no to the patient.
Absolutely.
So if the lesion is very, very vascular, we have to search if there is any surgical intervention can be done in this patient.
Yes.
So that is much safer than doing any kind of other intervention, because in the intervention, once the complication happens, it is very, very less likely that you are going to control that complication during the procedures, because we have a limited armamentarium, and that all goes through the rigid bronchoscope itself.
Yes. So my next question is to Pratibha Gogia. So when would you use a stent in malignant disorders, and which one? Because you have lots of types of stents available in the market. What would you use, and when would you use it?
Right. To make it simple for everybody, we are moving ahead of debulking, and now we have created space in the central airways. And if we are dealing with a benign lesion, then silicone stents are the stents of choice. So we have various silicone stents, plain with.
We are talking about malignant ones right now.
Yeah.
We'll take the benign later.
For the this thing, we put the silicone stent. But when we come to the malignant lesions, then our obvious choice is a metallic stent, and that too the covered metallic stents. So metallic stents are usually made of nitinol, and they are covered with polyurethane. And initially, when we started stenting, I'm talking about, first decade of the century, the covered stents were less available, or the ends were not covered. The whole stent was covered. The problem with metallic stents with uncovered ends or uncovered stent is that they are non-retrievable. But in malignancy cases, we are putting the stent with a palliative intent. So our intent is not to retrieve them back. So you will find many case reports in the literature where people are using metallic stents in benign diseases, but later on they become almost impacted in the airway, creating more problem and not helping the patient, rather troubling the patient. So on a very clear note, for the malignant lesions, we prefer metallic stents, covered metallic stents. And there are various type of metallic stents if you want me to elaborate on that. So, the brands are different. We have straight stents, we have J-shaped stents, Y-shaped stents, and these days we prefer to use fully covered stents. And in between the uncovered and fully covered stents, we have stents which have an end which is uncovered. They say by leaving a part of the stent uncovered, it embeds better into the mucosa, and the stent migration is decreased. The chances of stent migration, which is the most common complication after a stent, is decreased. But at the same time, sometimes if you have to retrieve or pull out the stent, because at times the stent can become a foreign body, can act like a foreign body. And if we want to remove the stent and we have an uncovered portion that is so badly tethered with the mucosa that it's almost impossible to take it back. So that is the reason that most of the stents these days are fully covered, and we deploy fully covered metallic stents in malignant lesions in the central airway. Even if we have a dual, means it has an endoluminal character, means endoluminal component, as well as in compression, as Dr. Pratibha Singhal said, that if the esophageal tumor is compressing upon the respiratory tract, it has not invaded the tract, even then we prefer to use a metallic stent.
Okay, great. So basically, when you have just a purely endoluminal lesion which can be managed by debulking, you don't put in a stent immediately, you wait and you see. If you have an extraluminal compression or you have a dual component, extra plus intraluminal, then you debulk followed by stenting, right, Ajmal?
Yes.
Yeah.
Ma'am,
Okay.
we have for a stenting, we have another comment. When we started doing a stenting, I agree, Doctor, whatever Dr. Pratibha was telling. But in our experience, I'm just going to publish in a day or two. I'm just going to make it to upload experience with 170 silicone Y stents. I think it is the largest in the country from the single center. So at our center, we prefer predominantly the silicone stent rather than a metallic stent, because with the newer kind of modalities of the treatment, we never know these patients will how many how many of them will get cured, and not even cured. Their bulk of the disease will get reduced. So in approximately 170 stents, we have removed stents in 35 patients. That is a huge number. And surprisingly, there is one disease, a tracheal tumor, primary tracheal tumor, that adenoid cystic carcinoma, which is very invasive carcinoma of the trachea. And approximately in 12 or 13 patients, we have placed a stent in adenoid cystic carcinoma. So what we have found is approximately 50% of the patient, we have removed the stent after the therapy. And I don't know whether you remember or not, Dr. Pratibha, one of the patient is in Bombay, and he had a lesion right from the just below the vocal cord to the whole of the trachea and right main bronchus, left main bronchus. We did the coring and Y stent placement. After that, he went to he came from your center.
Mm-hmm.
So that he went to Tata Memorial. He received a radiotherapy and chemotherapy, and after 3 years, we have removed that stent.
Okay.
So the removal of a stent is one of the options nowadays with the advent of these novel therapies, targeted therapies in patient. That silicone is at our center, at least we prefer more of a silicone stent than a metallic stent.
Okay. All right. So I think there is a lot of change in the way patients are responding to treatment now. There is a lot of targeted therapy available. Traditionally, what we have always learned is that usually earlier we used to land up doing stenting in malignancy more as a palliative, as Pratibha Gogia has already said. And I think there is definitely a little bit of a difference in the private sector and the public sector. You all have the luxury of trying all these things on your patients. In the private sector, really patients come right at the end. You know, they don't want to spend money out of pocket for the family doesn't want to spend money out of pocket for these expensive procedures sometimes, unless it is absolutely necessary.
But I don't think that now the things are, the rates are come up so down. It is hardly 30,000 difference between the stents. And one more thing is that when we are doing a procedure, sometimes suppose you have done a coring and you are placing a stent, sometime it may go wrong. We have a patient where the tumor was in the right main and left main as well as the lower part of the trachea. We cored and we cleared everything. And when we placed the stent, it went all right. So we just came out, and then when we auscultated, the air entry on the left side was very less. So thought maybe the patient will respond. So once we shifted that patient to the ICU, the patient is starting inflating like a balloon. So we thought it is one of the link must be in the mediastinum. So we did the CT, and we found that one of the limb was in the mediastinum. So we took that patient into that OT, and we removed the stent. And then in the morning, we again that cored out further, and then we have placed the same stent to the patient. So if that stent was a metallic stent, I don't think these could have been possible with these metallic stents. So silicon has a one luxury that you can rearrange your procedure and re-put the same stent in the same patient. Because once the metallic stent has been deployed, you cannot reposition it, or you cannot manipulate it after once it has been deployed.
Yes, Pratibha, you wanted.
What Dr. Ajmal says is an extension of the existing knowledge which he is publishing.
Exactly.
For the sake of the beginners, the clarity should be that what you have emphasized, sir, is very good, that it is the only advantage of silicon stent is that it is retrievable, removable, replaceable, which is much more difficult with the metallic stent. So the take-home message with all this discussion, that mainly metallic stent in malignant disease, but with an open option of silicon stent in selective cases where we are looking for disease regression to the extent that we can retrieve the stent. So that is a third aspect which we are now, with the advanced treatment for the cancer, we should keep into mind.
So I think all these interventions, anyways, in malignancy, it's always an MDD with your oncologist, right?
One more advantage of the silicon stent is that we have placed 12 Y on Y stents. I think this is the only center where we have placed a Y on Y stent. One Y is the secondary carina and the second Y is on the primary carina. So if with the metallic stent, I don't think it is possible to put a Y on Y stent, because sometimes reason is so that you need to put a double Y stent on the same patient.
Correct.
Another advantage of the silicon stent.
Correct. So it's great, Ajmal, to see. We'll see your publication soon, and hopefully things are going to move towards different scenarios. Moving on, Dr. Pradeep Dave, I think I'd like you to take this question. What are the common causes of benign tracheobronchial stenosis, and what is your approach to intervene in these cases?
Yeah, thank you, ma'am. It's a very good question. So as we all know, TB is endemic in our country. So most common cause of benign tracheobronchial stricture is tuberculosis, endobronchial tuberculosis in our country, followed by post-intubation tracheal strictures, that is called PITS, and post-tracheostomy tracheal strictures, that is called PTTS. So these are the three commonest cause, followed by we have tracheobronchiomalacia, inflammatory disorders like sarcoidosis and vasculitis can cause benign airway strictures, followed by we have lung transplantation is coming up in our country. So as we all know, there are 30% of the lung transplant recipient can develop a airway complication, leading to a stricture at the site of suture, where both the bronchus is suture with the donor lung. So these are the commonest cause, as I have narrated, in our country. Regarding the approach, if the patient is presented acutely with the stridor, your approach is different. And if the patient is presented in your OPD with just increasing dyspnea without stridor, your approach is different. Once the patient is in OPD and the patient doesn't have a stridor, you will do a CT scan, a spirometry. And with this detailed CT scan, you can have at least a judgment what procedure to plan, whether patient needs what procedure and at what extent. And if patient is presented with the stridor, then you have to be very vigilant regarding the management. So based on that, which anesthesia to choose, which airway conduit to choose, everything is different. So what we do in our procedure is we generally perform all the procedure under laryngeal mask airway and first time we do the balloon dilatation. And if required, then we convert the procedure into the rigid bronchoscopy and we'll do the mechanical dilatation of the strictures. So we have different modalities available. Depends on which type of the stricture. If it is a simple stricture, just we cut with using the electrocautery knife, and then we use a CRE balloon to dilate the strictures. And nowadays there is upcoming role of spray cryotherapy, where we do the freeze and thaw cycles of the strictures around the area, 30 seconds of freezing, 120 seconds of freezing, and then because it will prevent the injury re-injury phenomenon, which is very common with the electrocautery knife. Followed by the spray cryotherapy, we will do again the balloon dilatation of the strictures. So this is how we move forward with the benign tracheobronchial strictures.
Great. So moving forward, Samir, my next question is, once Pradeep has done the balloon bronchoplasty and dilatation.
Ma'am, before that, yes. I would like to say one thing.
Yes, yes.
As Pradeep said that there is this balloon dilatation followed by a rigid bronchoscopic dilatation. With the balloon dilatation, there is a multiple cycle of inflation and deflation. And again, with the multiple varying size of rigid bronchoscope, when we pass around to dilate the stricture, there is again a multiple cycle of passing up this that rigid bronchoscope. So there is available, that is called as a graninogen single stage optical dilator. It is a carrot shaped rigid bronchoscope, and we have published a paper, I think 2-3 years back. It is available in the Lung India. Optical dilatation tracheoscope. With a single passage, because it is a carrot root type of a rigid bronchoscope, with a single passage, you can dilate the trachea with up to the size of 18 mm, because that scope is at 18 mm scope. So the main advantage is what we have shown in that paper is before the dilatation, whatever that vascularization was seen on the means rim of the stenosis, after the dilatation, it was all intact. So there was a very minimum trauma with that single stage tracheal dilator. It is called as a graninogen. Graninogen is I think it is a space in Europe, place in Europe. It is named on that place. So one can find that paper on a Lung India, and you can see that, and you make use of it for the tracheal dilatation.
Great, Ajmal. So we have a whole spectrum of interventions that can be done. Of course, as I already said, Ajmal is a lead expert. Why? Because they have all the armamentarium available to them. Sometimes at a grassroots level, all this may not be available, Ajmal. So yes. It is important.
It is very simple. It is very simple. And after that, we published the paper. It is this same instrument has been purchased by PGI Chandigarh, AIMS, and in South, Kedar has brought that instrument. Yes. So it is not very costly. It is very means cheap kind of a instrument.
Yes, yes. So it's good. So we are coming up with more awareness of other options and other modalities available. So my next question to you, Samir, would be, once the dilatation has been achieved in a benign tracheal stenosis, one more thing I would like to add is, I don't know what is the experience, but we see a lot of GPA patients also who come with tracheobronchial stenosis. So that is one of the other causes of benign tracheobronchial stenosis that we see, other than what you have already mentioned very nicely, Pradeep. So Samir, would you stent all your patients of benign airway stenosis, or would there be?
Yeah, so we have the stroke trial that was published in May 2021, which was basically stenting versus balloon dilatation in patients of tracheal benign stenosis. So they included almost 66 patients, and wherein they came up with, as mentioned earlier, a simple stenosis and a complex stenosis. So simple stenosis is the one in which your tracheal involvement is less than 1 centimeter. And complex one is wherein the involvement is more than a centimeter and has malacia involved in such cases. So they clearly state that the simple stenosis should be treated with dilatation, and scar cutting may be performed with cold knife, avoiding a laser because the chances of restenosis are more. But in patients of complex tracheal stenosis is where you need to follow up the dilatation with a stenting. So whenever we are encountering a patient who has a complex stenosis is where we go for stenting. So I usually perform the silicone stenting. Obviously, silicone stenting has its advantages and disadvantages. The silicone stent is something that requires general anesthesia. You require a deployer assembly. For a lot of centers who are not doing stenting on a regular basis, you need to not only arrange for the stent, but you also need to arrange for the deployer assembly. It's a very expensive assembly. It costs around 4.5 lakh just to get the deployer assembly. So usually what happens is whenever you call for the silicone stent, the company will provide you with the assembly on rent, which comes to you, and then you have to send it back. So that's one disadvantage with the silicone stent. And often the problem with higher stents, specifically silicone stent, is migration, wherein you can do an external fixature or suture can be given. So a patient with subglottic stenosis or with a stenosis showing any mucosal inflammation, the dilatation will be the first option. And I believe it is not a very difficult procedure when it comes to stenting a patient, but you need a lot of experience. And the first thing is whom to stent and whom not to stent. Uh, Trust me, a stent is always problematic. There has never been a stent which has not caused any problem in the near future or distant future. Specifically, patients with benign stenosis are the ones who you don't expect palliative care. So when you're not expecting palliative care, you have to be extra careful with the patient's comfort. You need to counsel the patient as to the patient might require multiple bronchoscopies. The patient might encounter chronic cough. The patient might require nebulization with mucolytics. But yes, if you have a patient who has a stenosis segment more than 1 centimeter and you've tried balloon dilatation, is when you go for stenting. I think so. The metallic stent, although there is literature from China wherein the fully covered metallic stent has been used for benign stenosis, it's very difficult to remove a metallic stent. Nowadays, they do come with these black threads which are used to collapse the metallic stent so that you can remove the stent. But a fracture of stent is something that you don't want to have on your OT table, and sticking to the silicone stent is the best option.
Great. So I think basically when we are talking about stenting in benign tracheobronchial stenosis, one of the most common things that we are seeing is tuberculosis, right? And post TB sequelae. So they usually are multifocal, they are usually complex, and I think stents in them is as an interim procedure, right? Because it is not, it's going to be till you take the patient up for a long-term solution. The other thing is when you're using it for patients who have vasculitis, there sometimes once you've placed a stent and the patients have been put on treatment, sometimes they do well and you're actually able to remove the stent. So these are two complete different things. In our country, still the commonest cause remains post TB, and those are complex, usually multifocal, multi-level, require multiple sittings, and sometimes they also, because they're long-standing, they often have bronchomalacia where they would require some intervention. But yes, a silicone stent, as you said, I think it is not something that you're going to keep forever and ever indefinitely, right? So you would have to give a patient an alternative surgical outcome if it's a complex stenosis requiring with tracheomalacia once you have dilated and intervened. And the only reason why would you leave a stent in place for a long time is if the patient is not fit for surgery.
So very often we have these patients of post-intubation stenosis, mostly patients who've been mismanaged by somebody in either during trauma or emergency care. So these are the patients where you have to first evaluate and give the patient an option of surgical procedures, but then you need a center around you which is capable enough to perform a surgery. So that's when the role of stenting goes more important.
Yes. So my next question.
One more thing is,
yes,
ma'am, just an add on to that, like, what about if these patients have a recurrence or like to prevent a recurrence, what can we do? Like say, for example, we do use quite especially in stenosis, we do use after dilatation, we do use the use of mitomycin in these patients. So I think, and we have found that it is quite effective in these patients to prevent this recurrence. So I think Ajmal sir can probably explain on that.
I think that use of mitomycin is very, very conjectural. There was a paper from PGI Chandigarh, and I was involved in few of the cases where we have used the mitomycin locally to prevent the restenosis, but it does not prevent. So whenever we have a luxury of having a Dr. Arvind here with us nearby in Delhi. So we are in a conjugation, we are managing the patient with tracheal stenosis. So whenever possible, surgery, I believe that a patient should be offered for the surgery if it is surgically resected and reanastomosed in a good hands.
Correct. So there is some anecdotal data on mitomycin. A lot of us do land up using it, but I think large scale, there is no documented evidence as such of benefit over this thing. So my next question is, I think, which has already been partly answered, but Pratibha, just to take it, fiber optic versus rigid bronchoscopy, when and why?
I think rigid bronchoscopy increases the, use of fiber optics. So it's an extension of a single procedure, and rigid gives us more control over the airway. So when we see a case is simple, we have a simple tracheal metallic stent to be placed. The patient is spontaneously breathing. There is no distal blockage. The vitals are fine. I usually prefer to deploy a tracheal metallic stent, a central lesion, 5 centimeters away from the vocal cord, 2 centimeters, 3-4 centimeters away from the carina. So, sometimes we prefer to do it under the simple flexible bronchoscope and put the stent through that. And it's a easy, go. If the check bronchoscopy or radiology shows a lesion which is extended from carina till long into the trachea, one of the main bronchus or carina itself is involved, we prefer the rigid bronchoscope because we know that our procedure time is going to be long. The chances of having complications are more, and our rigid bronchoscope gives us a better control over the airway for oxygenation, as well as controlling the bleeding if it happens, or a massive bleed if it happens. Then rigid bronchoscopy is much more, give us a better control. So if I had a case of left main bronchus, totally occluded, I'm planning to debulk and put a Y-shaped stent. So I would definitely prefer a rigid bronchoscope. Whereas a simple tracheal compression from a esophageal tumor, which is mostly, into the starting from the distal trachea to the to the left main bronchus, we can do it under the flexible bronchoscope. But if you have any doubt about if the possibility of a complication is high, the patient is then rigid is preferred. But rigid has its own limitation. The mouth opening, the flexibility of the neck, and the cardiac status. So all the contraindication for flexible bronchoscope, along with some additional points before we post a patient for a rigid bronchoscopy. So everything has to be taken care of. But in most of my interventional procedures, I prefer rigid over flexible for the simple ease of ventilating the patient.
So I think just 1 second, Ajmal. I think, Samir, you mentioned a simple stenosis, right? I think that can also very easily be managed with when you have to do a quick dilatation with a single incision that needs to be taken. That can also be managed with a flexible bronchoscope. I think it's basically issue with how the training, availability, and anesthesia. I think that is what is this whole triangle of flexible versus rigid, and where it gets how some people prefer flexible, some other people prefer rigid. Yes, Ajmal, your thoughts, because you have the maximum experience with.
No, actually, I don't think there is any kind of a versus in interventional pulmonology. It is always and. So yes, one has to be it cannot be a rigid intention. It has to be a flexible intention. So it is not like that. Once you have a rigid bronchoscope, you will start doing an intervention without having a flexible bronchoscope. So they both are complementary to each other. And even during the rigid bronchoscope, most of the procedure we often require a flexible bronchoscope. So it is always a and it is not versus. So there are places where certain kind of things can be done with the flexible bronchoscope, and at places where only rigid bronchoscope is the main major approach. But in any case, flexible bronchoscope is a complementary to the rigid bronchoscope, and it has to be always present when doing a rigid bronchoscopic intervention.
Okay, great. So there are a couple of questions. Somebody wants to know about airway carcinoid management. Question from Dr. Rushi Rabari.
Actually, so far we have managed 12 patients of carcinoid at our center. And out of which we have 7 patients we have did a multimodality treatment. And on 5 patients we have sent it to the for a surgical removal. In a multimodality treatment, the major role is played by the if the it all depends upon the vascularity. If it is a very vascular tumor, it is better to have a surgical intervention and patient have a complete resection, because with the intervention, any kind of a modality, you cannot be sure of 100% removal, because whatever you can remove, it is only the intraluminal part. Maybe patient will have a extraluminal part as well, so it cannot be removed. So once the patient have a exclusively intraluminal part, intervention can be attempted if this vascularity is not the major issue. And multimodality treatment like coring or maybe laser, electrocautery, APC, all those are useful in these kind of situation.
Okay.
Not a single modality is means useful, because it is a collective effort of all the modalities that can be done through the rigid bronchoscope.
And Dr. Akmal, sometimes the carcinoid is present in liver and in other areas as well. So then chemotherapy and
chemotherapy. The major intention to remove the obstruction, airway obstruction.
Only to make the airway patent. That's
exactly.
all.
Yes. Another question is stenting preferable in patients with tracheobronchomalacia? I think that question, yes, tell me. Pratibha, you want to say something?
I think for most of the tracheobronchomalacia, we do not prefer stenting, as Samir correctly said that no stent is without problems. So there is nothing like a perfect stent which has been made till date. Even with the advent of 3D stenting, which are customized for the patient's requirement, still stent or no stent is always preferred. So we have to be very selective for our patients of tracheobronchomalacia, and rarely we stent. We do not stent all and every cases. Most of the cases of tracheobronchomalacia, we don't stent.
CPAP will be the ideal choice.
Actually, Dr. Dattau at Marshally, they are doing one kind of a procedure, is because the major problem in tracheobronchomalacia is the posterior tracheal wall. So what they are doing is they are laser burning the part of the posterior wall, so that the lumen is the luminal patency is stored rather than a stenting. I don't think they have published a paper on it, but on a personal communication, they were telling that they are doing a laser burning of the posterior tracheal wall for this tracheobronchomalacia.
Okay. So moving on, the next question is to you, Samir. In COPD, options for bronchoscopic lung volume reduction, any thoughts?
Yeah, so I'll be discussing the literature, but let me be honest with you that it's not my personal experience amongst all the questions that I've answered. This is one question that I'll be discussing. Whatever options are available, any experts on the panel who have personal experience can certainly join in. So the multiple options that we have is basically the endobronchial valves, the coil, there's thermal vapor ablation, and then there's targeted lung denervation. So all of these came into picture because there were a lot of shortcomings with the lung volume reduction surgery. So patient posted for surgery had a very strict inclusion criteria. That's when the bronchoscopic modalities came into picture. So it all started with the endobronchial valve. So these are meant to basically form a unidirectional flow wherein all the air during expiration comes out and the treated lung is vented, and then there is a atelectasis. Although there have been problems, one is the costing of the valve itself, and this is not in the one of the contraindication is patients who have collateral ventilation or parenchymal connection are the ones who are not suitable for valves. I have personally attended a few sessions during ERS, and the experience that has come is certain of these patients do tend to cough out the valves. So there are issues with valves why it is not being globally used in every place. And then there are coils which are basically spirals which are put inside the lungs. Here the advantage is coils can be used in patients where there is collateral ventilation established already. This was then followed up by thermal vapor ablation, wherein
Can we let
energy is given.
Pradeep take that other endobronchial
Yeah.
therapies in COPD?
Sure.
So I think from whatever data there is available, because we don't have these modalities available to us in India, what we have is Western literature. I think the coils seem to have worked better than valves. There have been case reports of valves being coughed out, of post-obstructive pneumonia due to valves. In fact, we had a patient who had a valve inserted in Dubai, and he kept having recurrent pneumonia, and we had to actually remove his valve and subsequently his recurrent pneumonia settled. So I think coils definitely seem to be better than valves. And Pradeep, if you could elaborate on other endobronchial therapies for COPD.
Yes, it's already taken by Dr. Samir. So there are two, three modalities like BTVA, what he told, and there are centers in India they are also doing. But it depends purely on whether you are dealing with homogeneous emphysema or heterogeneous emphysema, and depends on that they are doing. If it is homogeneous, then nothing will work. That's what I understand. But I don't have any personal experience. But when I went for a lung transplant fellowship in Leuven in Belgium, so they were doing lot of valve in COPD patient, and they were working. But you need a lot of experience. You need a lot of bronchoscopy after that for clearance. There is lot of infections. So I don't know whether it is commercially available, when it is available in our country, and how it works and how it looks in our country. I think we have to learn something from Dr. Ajmal if they have some experience at institution level.
So basically, these in whatever therapy is, that thermal vapor therapy is on. I think it is now being cleared in India. Other therapies are not available as of now in India. And the other thing is the cost, because in COPD is predominantly a poor disease in our country, and it costs more than lakh for a single valve or a coil. And in a patient, multiple valves or coils are required. And maybe it is in a single setting, maybe in a multiple setting. So it is the cost which may not be affordable for all the patient at our in our country.
Another thing would be, Dr. Ajmal, to have a volumetric CT to assess the areas. So which is also not available at many centers.
Yes. But that can be made available because it's a software only.
Right.
There's nothing additional to it. So, but the major thing is they are not available in India, and the other thing is the cost.
Yes. And the other things that are being studied, I think, in the West are some cold therapies also for COPD, for ablation of the airway fibers. So moving on, Dr. Praveen, often patients with hemoptysis, with large hemoptysis, come for intervention. So quickly, just a couple of lines on what options can you offer these patients? You're on mute, Praveen.
Yeah. So when a patient comes with massive hemoptysis, the primary aim is the protection of the airway, and then followed by a resuscitation. So the basic things of protection of the airway definitely has to be done. If we need to intubate the patient, an urgent intubation is definitely required. Clear off the secretion. So if we have an option, I mean, in an experienced hands, if we have an option of rigid bronchoscopy, most of the time rigid bronchoscopy gives a much better and probably an easier option, and you have a more you have a more area to work with. So, but if you are not experienced with that, because that it takes some time. If you're not experienced in that, then go in for an intubate the patient, and then try to suck out all the secretion, clear off the secretion, remove the clots, and then get a patent airway at least make the airway patient, I mean, help them to breathe. Once it is done, then probably we can use a variety of techniques, the things like ice cold saline irrigation to prevent this, to prevent the bleeding. Usually, the things that we generally use is, first we use an ice cold saline. Multiple aliquots of the ice cold saline is injected, and then try to remove it, and then followed by, if it's still continuing, we use the topical epinephrine. Usually, in our center, what we generally use is this 1:20,000 is what we generally use. So any patient, any sort of intervention, when we are beginning to start, these things will be at hand already, so that if the bleeding happens, it will already be it will already been started out. So then this will be followed by any if still there is some amount of bleeding, then we can definitely try instilling this drugs like tranexamic acid. Still the bleeding is there, we can try the balloon Tamanat, using this ARN blockers or Fogarthis. Only problem with the Fogarthi is that we can't keep the Fogarthi for a longer period. But if you have an ARN blocker, yes, we can definitely keep it for a much longer period. Things like if it's an oozing which keeps on going on, then probably we can try the ones like Svigots, which can use it. But there are thermal ablative techniques, like say if you have a laser, which is, as mentioned earlier, much costlier way. If you have a laser, then definitely it's an ideal way to coagulate that area. In our center, we don't have it, so we use usually the argon plasma coagulation. That is the commonest thing that we use to, once we find that there's a bleeding in some area, some specific area of the airway, then we try to use the argon plasma coagulation to. We can also use the ones like cautery, endobronchial cauteries, and all these to directly apply the electrical energy to clear that area. So whatever way we are using is, we need to try to control that and then get a patent airway so that the patient will be able to, breathe. And meanwhile, then try to do the definite procedure, like say bronchial artery embolization, or so that the patient will not, prevent the further bleeding.
Pratibha, my next question is bronchopleural fistula, prolonged air leak with a large airway involved. What are your options for therapeutics?
I'll make it short. I think we are running short of time. So central airway fistulas, mostly after lobectomy, segmentectomy, or pneumonectomy. The rate is very high. Most common causes infection of the pleural space after the procedure. So we try to control the infection, but if still this thing persists, we have used multiple things to block those fistula. It depends upon the size of the fistula. The size is 2 mm or less than 2 mm, which is very rare to happen. We have instilled glue, cyanoacrylate glue. The glue used by gastroenterologists, we have, with the help of a TBNA, conventional TBNA needle, through the flexible bronchoscope, we reach the site. At the site of the fistula or this thing, we just put the end of the needle is cut, and we instill the glue, and most of the time it works well. If not completely block it, it makes it smaller. And the bronchial tree, that saves the bronchial tree from getting this thing by the secretions in the pleura. It doesn't get infected by the secretion, and with antibiotic it heals with time. If it is very large fistula, I have the experience of using Emplatzer devices, which are used in ASD, or we have used, in one case we have used a patent ductus PDA closure device, which we have published in Lung India as well. So the diameter of the fistula post pneumonectomy fistula was almost 6 to 8 mm, which is very large. So in that case, we have to think innovatively, and we have to depend upon a duct occluder device, which we borrowed from our cardiologist, and put it into the central fistula using a bronchoscope on one side and C-arm or fluoroscope. We did it in the cath lab. So with the help of this thing, we used the Emplatzer device. But here the question was, why didn't we use the pleural route? We could have entered the pleural space through our thoracoscope, which we avoided because we thought that if we lose the Emplatzer device into the pleural scope, it will be difficult. It will be like creating a foreign body. On the other hand, we found it much more controlled environment because we put the device from the bronchial side through a flexible bronchoscope over a guide wire under fluoroscopic guidance as well as under vision from the bronchoscope. Other options which we have used are gel forms, but they are really tricky to implant because you have to make a spigot or a round ball, hold it with a forceps, put it into the bronchoscope, and together enter the bronchial tree and put it there. sometimes they move and they can fall into the pleural space. Another thing we have used to block central fistulas are spigots, though which are not now, which are available for few years, 2 or 3 years. Before that, they were not officially available. So we were using any sterile material like surgical gel forms to close that. But now 1 or 2 cases I have used after localizing the fistula through our radiology. And then we have put a spigot which come in 3 sizes, 4, 5 and 6 mm. But again, putting a spigot is tricky. It has to be either put on a guide wire or it has to be held with a forceps already passing through the bronchoscope. Together we enter and try to put the spigot at the fistula side and try to seal the corners or edges of the spigot with again a glue so that it does not fall neither into the bronchial tree nor into the pleural space. So it is an imperfect science of closing post-surgical central bronchopleural fistulas, and these are few of the options available, Dr. Pratibha.
Yeah. So I think these are more when you don't have surgical options that is an option for the patient. That is when we resort to these options. So interestingly, when you spoke about why did you not use the pleural approach, I just want to share one case which we had done recently. We had in fact put in 2 spigots. We put one bronchoscopically and the other one thoracoscopically. So we had to put 2 together to eventually ensure complete seal of the spigot, because we put in 2 spigots bronchoscopically. One of them got dislodged and was floating in the pleural space as a foreign body. So we went in thoracoscopically to retrieve it, and then we used it to plug it from the pleural side. So multiple interesting things available. There's one question this is the last question we're going to take. Ajmal, this is for you. Management of tracheoesophageal fistula.
Basically, what Dr. Pratibha is telling, I think they are the major center where they are using managing these kind of a patient of tracheobronchial fistula. We are only managing tracheoesophageal fistula here at our center is a malignant one, and that is more likely with the stent only. And in majority of our dual stenting, they were a patient with tracheobronchial fistula. So I think Dr. Pratibha has already covered most of the answer for the other modality as a treatment for TOF. So I think that is all for this.
Great. So I think we are already, it's 9:12 now, and I think we have extensively discussed all the interventional modalities in airway diseases. And I think, I hope this is the first session of this series of intervention pulmonology. There are a few questions in the chat box, but
just give me a few minutes. I just want to show you one thing very interesting. I'm just sharing the screen. Can you see it?
Yes.
It is. I think it is a very rare condition. It is called a plastic bronchitis.
Yes.
So it is almost 8 centimeter mass. It has been removed from the left main bronchus, and patient who was a complete collapse of left lung has a complete means expansion of the left lung after removal of this. So it is taking the shape of the bronchus itself. It is a plastic bronchitis.
Yes. Great, Ajmal. So I think we should wind up this session now. I thank all the panelists, Ajmal, Pratibha, Gogia, Praveen, Sameer, and Pradeep for this lovely discussion and interactive session. And I thank ICS for giving us all this opportunity to be here today. Good night, everyone.
Good night, Ma. Good night, Dr. Pratibha. Nice connecting.
Yes, thank you.
Good night, all.
Good night to everybody.
Thank you.
Good night.
Good night, everybody.
Good night. Great to be here.
Thank you.